everyone, and welcome back to Clinically Correlate with Azfar and Vedant. Episode 5, we have our very special guest and our good friend, Vineeth. In this episode, we have a lot to talk about, and hence we'll divide it into 2 parts. In part 1 of this talk, we'll get into Vineeth's background and why he chose the field of interventional radiology, and sort of both the challenges and the future of diagnostic and interventional radiology. Stay tuned. All right, Vineeth, tell me about yourself, man.
All right, so I'm Vineeth. I grew up in California. I went to Stanford for undergrad and then went to Columbia for med school. And then I'm here as an R1 at Penn. I have like a lot of interest in kind of the combination of computer science and like radiology. And it's kind of something like you could say it's very unoriginal because my mom's actually a doctor and my dad's a computer engineer. So actually I grew up with kind of being at the intersection of the two for kind of a while, and like had always heard conversations about like mom who absolutely hates the EMR system, and then my dad being like, oh, why don't doctors do this? Like, why don't they just use like computers to do that? But it like wasn't necessarily kind of always the plan. They were kind of like 2 separate spheres of my life. Like computer science, like I found kind of in high school, I liked robotics. Like I like Legos a lot. I found myself on like a Lego robotics team, and then just had to learn how to program to do that. And then realized that was just like kind of like this hobby that I wanted to do. And then medicine like kind of was like the job that I always wanted to do, just because like it's really boring, like going to your dad's work as a computer engineer and watch him like work on a computer all day. Whereas like seeing what my mom did was a lot more exciting. So like at one point it was just a hobby, and then I found like you could actually fuse them into a career, and like that kind of pushed me into radiology and interventional radiology.
So I was gonna say, it's like, oh, it was really boring to go and watch your dad sitting in front of a computer and work all day, and here we are in radiology.
Like the irony behind it.
Sitting down, just like dictating all day.
Maybe we stand up a little bit.
I know, we were standing desks. They didn't have standing desks back then, but now they do though.
Yeah.
I know, I called my dad. I told him the only difference between your job and my job is that the lights are off at my job.
So you kind of touched upon how you were between computer science and medicine, how you were able to kind of integrate your love and passion for both of these together in medicine, jump into radiology. But why interventional radiology specifically?
Yeah, I mean, interventional radiology, diagnostic radiology, the entire thing actually, like it's like a little bit of both and everything. So I would say that with interventional radiology, so first off, the entire like radiology in general, I was actually very against radiology, like pretty much all of my med school, because I think part of it was like a reaction to like everyone would just pigeonhole me, like, oh, like you say computer science, you should be a radiologist. Like, so it's like every single person I met would tell me that, and just like as a knee-jerk reaction, I'd just like, no, I don't want to do this. Like people had told me even about IR, like so my response would be like, look, I just left computer science. Like, why would I go and do a job where I'm just sitting behind a desk all the time, right? Like. And then they're like, oh, you should look into IR. And like, I was already just so turned off that I didn't even like look into like IR, even though like they were actually like, it's what I ended up deciding to do. And it actually wasn't until my clinical year. Like I was jumping between hospitalist, then psychiatry, then neuro. And like on my surgery rotation, which like they asked me what I wanted to do, and I said not surgery on my first day. I actually really liked it. I loved surgery. I loved the way they thought. It like really spoke to my sensibilities as an engineer. Like it was like all pipes and tubes, blockages here, it just all made sense. And like I didn't really like open surgery. That wasn't what I liked, but the way they thought about problems just felt very intuitive to me, very different than a lot of other parts of medicine. And actually my intern that I was working with, he was actually a prelim going into IR. And so I was like talking to him about like how surprised I was to enjoy this, but how I didn't really like open surgery, so I didn't think it was like the right choice for me. And he was like, you should really look into IR. And this time it felt different because it wasn't some guy just being, oh, you're computer science, you should do radiology. It was like, oh, like something that was actually more core about like how I interacted with the field. He was like listening to that and then suggesting it. And after that, I was like, okay, yeah, like let me think about it. And then I found the field, looked a little bit more into it. And then really fell in love. Like I think like one of the big key points is like I was listening to a podcast, not this one, but and they asked like, oh, like what's like the number one thing like you like one number one quality for an interventional radiologist, and it was creativity. And like I had just never heard any other medical specialty say that. Like maybe like I'm sure it's important for many medical specialties, but I've never heard someone say that's the number one thing. And like as someone who like really does identify themselves as like an engineer, like it's something I felt like I was missing in medicine. So like from there, then it like was like, oh, like what you can do for patients in a minimally invasive way, like that. Like I came into medicine to like help people and to be able to do that in a way that's like minimally invasive and like gets them more time at home, like doing what they love. Like that's like, I mean, no brainer at that point.
Yeah. I mean, I think what's crazy is like, especially among like the IR residents, our stories are so similar, even though we all kind of have like different backgrounds. And like ultimately it comes down to like kind of surprisingly liking you like that you like procedural specialties. And like you said, like the intersection between a lot of other aspects of clinical medicine and the creativity part, which I think like creativity, thinking like, is there a better way to do things is kind of like the backbone of IR. And I think just that's what gets us all excited.
Yeah, definitely, definitely. Yeah, it's nice to be in a field where it's not all like kind of doesn't feel all set in stone.
Yeah.
Like even the way we practice in IR, like there's like I don't know if there's any other field that's like constantly just like trying to figure out how we even fit into medicine.
Yeah.
And I think medicine's going for a change. Like I think and being in a field that's actually critically thinking about how we fit in, what's the best ways to like deliver care to patients, where in the value chain we sit, I think we're actually really well suited to be in a kind of a turbulent times ahead.
Yeah, I mean, I think we've all had like a lot of conversations about that, right? And then like even like you said, there's so many different practice patterns within IR. And then even before the podcast started, we were talking about value-based care and kind of tangentially of how that will impact radiology. And definitely, I agree with you that I think like IR for sure is going to come out a winner in value-based care because a lot of what we do, it's kind of we've been in this background and back end, but like we help a lot of patients leave the hospital faster and in a safer way, and all that stuff is maybe not being identified in the current system, but definitely when you start putting that value lens, it's definitely going to be there.
First of all our residents have to go through like a DR training, right? What do you guys feel about where the field is headed in terms of kind of separating DR from IR? Like, will we see that separation in the next decade, or do you think IR will always or do you think DR will always form a core part of IR?
I think there's like one good point in history to look at for this, which is radiation oncology. And I don't know too much about the specifics here, but I do believe at one point, like that was another field where people were often double boarded in rad onc and radiology because the training was linked together, and then now they're separate fields.
Right.
So I would put that as one historical point where it's like maybe something similar will happen there. And I don't really know the full specifics of what happened, but I think like looking to history to kind of answer these questions can be useful. At the end of the day, though, imaging is a superpower. Like I think like being able to read images, like at this point, like modern healthcare is like built on top of imaging. Like you just can't do it without like being able to see into the body like we do. It completely changes like the way like you can practice, and like the ability to get training from the source, like from radiologists who are reading it every day rather than from someone who like is reading the reports and then is trying to teach you like but is not like fun, like that is like an irreplaceable thing. Like that skill set is a superpower, 100%. And I do think it like lets IRs do what they do. Is there a different shift to like a different balance to strike? Maybe, but like it is definitely a superpower to like get this training and imaging.
No, I think I very much agree. Like you said, the comparison to radiation oncology is very appropriate, and also like say vascular surgery to general surgery. At some point, I think it's it comes down to, do practice patterns once you finish residency, are they so different if compared to the other specialty that you need to have a break from that? And I think we've seen that in some IR departments in academic places, if they have their own standalone department, or just like standalone IR clinics and private practices. And if that continues, then I think like that will reflect the training. But as long as that practice pattern still stays that like you have an imaging contract and then like radiology within that kind of splits up who does what, then in that case, then I think like the training is just going to continue being the way it is. But to that point of, there are some things that probably are just not that valuable for an IR to learn if they're ultimately not going to have to practice it, and vice versa, right? So like, if you're going to be a diagnostic radiologist, like to what extent seeing like cases and trying to like scrub in and doing these is going to like be impactful for you, and like you'll never actually have to practice it.
Yeah. And like I feel like some people sometimes will like push back to that and they'll be like, oh, but you'll be reading like the imaging related cases. I mean, that doesn't mean that you're going to go out here and do neurosurgery and all those other things too.
Exactly.
Like that argument doesn't fly.
Yeah. What do you think?
I think I think I kind of agree with you because I went to a small hospital for my transitional year, right? Where that hospital had a contract, and even the IR docs were doing 50% IR and 50% diagnostics. And again, diagnostic radiology, high-end imaging are bringing in more money. And the reason why they had IR docs in the imaging group is because the contract specified so. And I don't think IR is sort of big enough at this point where they can kind of serve as their own group, so to speak, separate from diagnostic radiology, right? So you can have a separate surgery group, right? You can have a separate neurosurgery group, a different surgical group, and a different even vascular surgery group, right? I don't know if IR has gotten big enough where they can kind of form their own group separate from diagnostic imaging, especially because, given how they're training now, they can also be used as diagnostic radiologists.
So this is actually great because this is actually probably the exact tension between diagnostic radiologists and interventional radiologists.
Yeah.
I think there is this conception that like interventional radiology is limited and doesn't necessarily have like a whole lot of scope. And not to get too political, like this might be in the hot takes section.
Yeah.
But it's
fast.
yeah,
Skip right there.
All right, yeah, dude.
but, like so it's kind of interesting because like you think about like how much stuff is endovascular, right?
Right.
It's actually an increasing amount, right? Like you look at neuro-IR, there's a lot of it that's happening. You look at vascular, there's a lot of it that's happening, like a lot of interventional cardiology, right? Like they took a lot of stuff from cardiothoracic.
Yeah.
So the idea of doing these image-guided procedures, minimally invasive, that field is a large field, right? There's certainly a lot of scope within that field. Now we have to ask ourselves, why is IR not doing that?
Yeah.
Right? Because that skill set is it's very applicable to many things. And one possible argument for that is that, like, let's say, what is the role for radiology in a hospital? Part of it is like it has gotten a really commoditized field, right? And you're talking about like why, like the diagnostic radiologists pull in more money in the group. Like reading pulls in more money, right? But then like the reason why hospitals can't just like play a bunch of radiology groups against each other is because they have that clause where you have to have an IR. So like why don't they just pay the IR less? It's because they actually do need the IR. Even though the RVUs aren't high, the IR is absolutely necessary to anchor that contract. Right? Because they're definitely not pulling their weight in terms of RVUs, but they are pulling their weight in terms of like overall value and keeping that contract. But the thing is, what are other things that makes the hospital happy with it, right? Like the hospital wants to like their radiology group. They want them to do fast reads, nice reads, good reads for everyone, and not step on any toes. They want the IR group to be available to deal with the complications and not step on any toes. What does step on toes? Doing the aorta works, doing the PADs, doing all these other things, right? Like that would definitely step on a lot of toes. So the diagnostic radiology group is definitely not going to be out here supporting the interventional group because that might make them lose their contract because a lot of the people in the hospital might get angry. So and then the thing is like, there's also a non-compete because normally like if you have like, it's specialty based. So like if you have a radiology contract with a hospital, you can't just have another radiologist because we are dual trained, like show up because it's a non-compete in the thing saying that you only can have one radiology group. You can't just have someone else doing it. So even if they're not giving a service, like a PAD service in the hospital, even if that's not even there, you can't, like a radiologist can't come in and start providing that service because like that's a radiology group coming to that hospital. However, a vascular person can do that service. So that's actually one thing that like SIR talks about is the idea of like for procedures where there's overlaps between multiple specialties, like excusing the IRs from that non-compete so you can actually still allow IRs to do this if they want to do it. Because I would argue that there actually is a ton of scope. It's just that we've kind of gotten backed up into a corner and we can't practice these things.
Yeah, I mean, I think those are all like great points, right? And to give context, I think, the reason the diagnostic folks bring in more RVUs is that it's more efficient, right? Like when you sit down for the 8 to 10 hours that you're working, every minute besides your breaks that you choose to take, you're bringing in RVUs. And there's pretty much an endless stream of imaging studies to read. So people can calculate what your optimal like RVU basis for that day is going to be. For anything that's going to be procedural based or clinical based, it's a lot more variation. Whether, say, like a classic surgical model, on the days you're seeing patients in clinic, you're providing X number of RVUs, and then you probably 3 times that on the days that you're in the OR. With IR, it's kind of in between because a lot of our procedures are not as long as the surgical procedures, and at the same time, we're not seeing as many patients in clinic, so you have a little bit of like a more standardized but still varied stream throughout the day, right? And then especially some cases can take longer than expected. Now you're, spending more time for the same amount of RVUs. I think the other thing that you kind of touched upon was, with the actual imaging contracts, they need the diagnostic radiologist to provide the reads. But what is kind of, I think, like not discussed is it's not just the RVUs that IR brings for the procedures they do, but the opportunity costs of not having an IR available, right? Because the hospital then has to tell a patient, we can't do this, and then they can't accept a patient. They have to transfer them to some other hospital, right? And like these are real considerations that like, for I think most hospitals have all the major subspecialists, but like I mean, I'm sure at like the community hospital you were at for your intern year, and definitely for me at the VA, there were a lot of times we were like, yep, we don't have the service, like go somewhere else, right? And like that component, and especially when you add in like acute complications for patients that are already in the hospital, like you said, like you can't do anything if you don't have that service, right? And so like us being on call for the weekend, sure, it's not like you can say I brought in X number of RVUs for working those 20 hours, but like theoretically it would be a huge loss for everybody if like you didn't work that.
Yeah, it's like one of those things where you miss it a lot more when it's gone.
Yeah, right. And then I think the final thing of like, these other specialties doing image guided procedures, the reason they even were able to take those procedures from the ones that trained them, which were interventional radiologists, is the fact that they said, we see these patients, we know the clinical background, we'll see them in clinic before and after, right? And then one makes everyone, I think, feel more comfortable of like seeing that person for that major procedure. And then two is very easily to say, you should just come to me. And then why would they refer it to an interventional radiologist, right? And so like in the context of that, with like like the traditional radiology practices not really having a clinic, and then that infrastructure being there, which is a totally different setup, that I think is kind of where we've like that's like the history of where we are right now and dealing with it.
Yeah, without clinic, I don't think IR can move forward. Like it'll just keep losing things. We need clinic.
Well, I think like what's interesting about that, and we kind of touched about it in like I think our second episode about talking about intern years, right? I think what's like cool for all of us is like, we did an intern year that was outside of our medical school, different from our residency, and like relatively community to like a mixed community academic like basis, and it just like I think gives that perspective of like once we finish residency, like there's so much variation, right? Not just radiology, but just like how people are doing things.
Yeah, absolutely. Yeah. I think that that's one thing that like really, like at the end of the day, everyone goes to medical school. You can do that. Medical schools are by definition academic, centers generally. And as a result, you see one type of practice, right? And like, you can say, oh, you can shadow a bunch of it's not the same. It's not the same as like working in them. And like, I think that that's huge. I think it's like a really big deal to like see what is actually out there, what life is like, because it's very different. Like vascular surgery at an academic center versus at like a private practice, very different.
Absolutely,
And to be honest, like I think it's also very good to know for IR too. Like IR is very different in both places, and also like it's also the problems that you face, right? Because like you may want to you may want to do high-end IR in a community setting. There's no reason why you shouldn't. In some senses, we actually require less infrastructure than like a full surgery center and stuff like that. So like it's technically feasible to do really high-end IR in like these kind of like non-academic settings, but that's like it's hard to learn how to do that because that's an entirely different skill set that like we get trained in these academic settings. Like all these like referral patterns are all kind of built up for us, and you go out to like private practice and you have to learn that from scratch. Like that's tough. And it would be nice to kind of do rotations. Actually, I think that's one thing that we kind of lose with IR becoming integrated. Before, you'd have this cross-pollination where people would go from one institution to another institution. You'd see different styles. It would open your mind to them. There's possibilities like what's dogma versus what's real. I would love to see IR like start to do like kind of these away rotations for residents, where you just kind of like spend a few months cross-pollinating ideas. I think that would be very good for the future of the field.
Definitely. Do they not offer that option at Penn, or is it like not a thing?
It's not really talked about much. Stanford actually, I don't know if they offer this, but I know there's one of their like I think maybe their chief resident. I remember listening to a Backtable podcast where I think she was actually talking about this idea. And it really kind of stuck with me.
For sure.
Yeah, I mean, I'm sure like we have elected time, right? But it's highly unstructured, which is probably a good thing. But like that would definitely be something to consider.
Yeah. And it might change. Like they're already talking about fellowships and stuff, and that's what fellowships normally give for other people. Like you have
So
the chance
fellowship
to talk
on top of your eye.
I know. Yeah, I can see like, the look in your eyes.
I was like, hold on a second. Are you talking about a neuro-IR fellowship? Because I can get on board, but like what?
No, I mean, so this is why I found it really kind of interesting. Like this, like when you said earlier, like, oh, like IR has such a small scope. The scope is huge, man.
Yeah.
Like the scope is absolutely enormous. Like, and you really don't see it until you get into it. Like MSK interventions is really ballooning. Like what you can do is amazing.
So it's like, who does it though? Is it the MSK radiologists who do it, or is it the IR folks who do it?
Well, yeah, it's mixed. It's mixed between those two. It's mixed between PM and R, mixed with an ortho.
Right.
Like, I don't know. I think it's like important to kind of take a step back and like just kind of focus on like what is like the goal of medicine, right? It's to treat patients and it's to be able to do it as best as you can. And I think we get into this kind of like thought process of like tribes, like, oh, I'm this, I'm that, I'm this, I'm that. And I think sometimes like it's important to like actually stay true to like the actual value you bring to the table and like understand like you don't need to like bring yourself into these tribes. Like just be like, okay, like what can I do to make sure I take care of the patient in front of me as best as I possibly can? Like you can read books from other things. Like most of us self-studied for med school. Like it was not from the school's information, right? Like being thoughtful, being humble enough to know what you don't know, right?
Yeah.
Being humble enough to know when to ask for help, right? And being quick to ask for help. I think you can do a lot if you just focus on the patient in front of you. And that's kind of why I look at DR as like not like it's a superpower. Like I want this. I think it's a valuable skill set, and I want it, right? And like even if I don't necessarily practice as a DR, I want to be able to look at an image and see like you guys do, right? Like and like how I will be board certified. But the board certification to me isn't as important as the fact that I can see it.
Right. Yeah. So I think the tribalism point is a very important one because, as you said, the overarching goal of medicine, or the idyllic goal for medicine, is to treat the patient in front of you. But the corporate side of medicine wants to bring in as much money as possible.
Don't get me started on the corporate part of medicine.
And this is what gave rise to tribalism in medicine, right? So it's very easy to think about what diagnostic radiology does, right? Okay, imaging, any sort of imaging will be the masters until you think about echocardiograms of the heart. You're like, oh, wait a second, we have zero exposure to that in all 4 years of our diagnostic radiology residency, right? And then you start thinking about IR. It's actually pretty difficult to kind of jot down, okay, what are the core procedures for IR, right? Is there and something that only IR does that no one else does, and that's like, okay, if I'm thinking IR, that's what I'm thinking.
Lines and tubes.
Lines and tubes, right, for sure. Lines and tubes.
No one else wants.
Exactly.
Right.
If somebody jumped like 10x RVUs,
Everyone, 100%. Like IVC filters, right? You can see like the evolution of that when it is valued highly or not.
Yeah. So it's like, okay, so you put those, right? And then you think about, okay, IR has this huge scope.
Yeah,
but everyone else is coming for that piece of pie, right? So then the question becomes, if you do end up doing a fellowship, right? You do the super training, and what you end up seeing 5 years down the line is, oh, it's gone to some other field who own the patients, quote unquote.
Yeah,
right?
I think one possibility is the idea of like mixed specialty practices. Right?
Yeah.
Like that's one possible way. Like I've heard some cases where that's not gone that well, but to be honest, in my mind, value-based care actually kind of starts to solve some of these problems. Then it just becomes like, who does this better? Like if in this situation where like you get paid that money, like just by doing like if you're like, then like why wouldn't you want to do it, right? Like for radiology imaging, like why wouldn't you, like if all you have to do is just attest to the report and you get the money, why wouldn't you want to do it, right? Like if you're just looking at it financially, like there's no part of this right now where it's like it feels like you're actually like it's only on the litigation side. That's where they punish you for just not saying normal in every single report, right? And the part where you sleep at night,
right?
Right, like.
So with value-based care, right? So let's special. So you get a certain amount of money for a certain type of or diagnosis, the type of care the patient gets, right? So how can value-based care solve this, right? If the hospital is getting a certain amount of money for a patient coming in with a PAD, right?
Yeah.
If the hospital already has existing contract with vascular surgery, they'll just give it to vascular surgery.
Well, it depends on who can do it better and cheaper. Right.
Okay.
Like because the cheaper becomes the other thing, right? That's the value part of it. It's like the numerator denominator of this. And like there's a lot of literature actually within IR already that shows that like we are actually generally able to do the same procedure for like half the cost compared to a lot of other things with like equal to less complicated.
So I'll chime in. I think, the value-based care component to it has a bigger bigger effect on the outpatient side. Mainly because in the hospital, right, like at best you're competing for a matter of days of who can do the procedure, right? But in the outpatient setting, like if you can do it faster, cheaper, and you're just more available, right? Then you have a different, completely different referral pattern. And then I think if you're a referral, like a referring physician in the outpatient, you're not going to care what the qualification is at the end of the day when you're like, I just want what's best for my patient, right? And so and especially with the difference between like the outpatient side and then the inpatient side is hospitals have to try to take care of everyone that comes in to their hospital, right? Like unless you're a subspecialty hospital, like a cancer institution, you're just like one day it's a PE, one day it's a heart attack, and one day it's like your oncological patient that you're like doing a full workup and doing a major surgery at the end, which I think fundamentally you can't like it's way too many variables to predict for. But like the outpatient side, when you're like say a nephrology practice and you're like, I have 5,000 patients in this major group and I know what disease patterns they're going to have, I can predict them, and it's like you can start having a pathway. And now the interfacing points with different specialties, if you're asking them not necessarily compete but to show value for those, I think that's where we can be very beneficial.
Yeah. There's an interesting article actually, like in terms of value-based care, right? Like there's like all these questions about, okay, is this going to be a government thing? Is it going to be like the VA? Is it going to be like this? There's another thing that I don't think people talk about a lot, which is like kind of like goes to like how health insurance started in the first place, right? Like employers like were providing health insurance because part of it is that's your workforce, right? When they're sick, they can't work, right? So Walmart, right? Like they cover a lot of people around the country, right? They're like one of the biggest employers in the country, and they're one of the most geographically spread across the country. The problem of how do they give these guys health care is actually a really big problem. So like, for example, like back pain, there's this great Harvard Business Review article like that covers this like case. And they found that like spine surgery in different places, different parts of the country, there's very different outcomes and very different costs and not that much correlation between the two. And so what they did is they identified like areas of the country where the care is really good, and they started funneling people from like the areas where the like outcomes were like the value was low to the areas where the value was high. They basically said, hey, we'll pay for it all, right? Because it matters to them. Because someone with back pain, right, this guy isn't going to be able to work as well, right? You want to take care of them, not just because you're a good employer. It's because like this is a cost for you.
Right,
you want to do like good for your shareholders. It's not altruistic, right? And it's really just like there's no bureaucracy in this. They're just like cold hard cash, right? And then it starts. So then that's like one way where like if you can kind of prove that you're doing things cheaper and still getting good outcomes, like there are stakeholders, right? There are stakeholders that are not like where they want that. So like there's pathways.
Yeah, and I think what's interesting about like the orthopedics, like hip and knee replacements, I think that study focused on is that like hub and spoke model works well for very episodic care, right? And so like, maybe you plan out and you're like, I have a 1-year recovery pre and post that surgery and that's it. And so that's why like for that, you can fly them to Arizona and have like 10,000 like replacements done there and nowhere else in the country. And then like on the flip side for why I think, like healthcare is still local is things like onc care or dialysis 3 times a week right there, right? And so like, what are you going to do? Try to fly them? And so like, it's like, it's those considerations as well that like timing is the biggest thing. It's probably the bane of our existence in terms of like you have to be available for call or ED, studies and stuff. But that's our lifeblood, right? Like providing value in that local area.
Yeah. But the thing is like, so like, yeah, you talk about dialysis and stuff like that. Yeah, like absolutely. Like something's hyper-local, right? Heart failure, exacerbation, who knows when that's going to hit? You're not timing that, right? Like, but the thing is, identifying like even local like differences between like people providing care, right? Like if you can identify and predict who's going to be doing that for cheaper, hey, we're saying there's an easy way to predict that. Send them to IR.
But I think one of the interesting points you made was the way for IR to not just to stay afloat but to succeed in the future is to kind of, it sounds crass, but kind of owning your own patients, right? Where you're not just a transient service that people take care of. Where you sort of follow the patients at least for a short term, right?
Yeah. At the very least, what we need to do is we need to be able to say, hey, send us your patient, we'll take care of it.
Right. Yeah.
Right?
Yeah.
Like, that's the thing. Like it's not okay if someone says like, hey, we're just like, oh, nope, not our problem, and then like don't give any like recommendation of who to go to next, right? Like we need to at least understand what the other options are, right? Like, and understand like what the different what are the different options, who can do them, right? Even if we can't do them, I'm not saying that we're gonna out here do the surgery. No, absolutely not. Like we should have like the knowledge and a good relationship with the people who can, and the right indications to know when we're gonna help and when we won't. And people need to trust that we know that.
Yeah. And so to do that, right, I feel like that would require sort of a paradigm shift in terms of how we are training folks. That would require a shift away from this diagnostic radiology training into a more pure form of IR training.
You know, part of it though, I would say radiologists do a really good job of understanding a lot of different specialties and a lot of different indications, right? Like we talk about all the time, our attendings will be like, this is important to let the clinician know because that's going to guide management, right? That's exactly what I'm saying that IR needs to be able to do for our things, right? We just need to know what are the key things to know to guide management. And you know, it's hard for diagnostic radiology because we move so fast, right? And that's not necessarily our fault. Like, and sometimes like things get missed because we don't have all the information. Like at least like hopefully with IR, like we can slow down a little bit with the patient in front of us, really think about these things and do it the right way. But like I think the knowledge honestly is like there. It is baked into our training. Yeah.
All right, so should we keep going with the hot takes?
Yeah, I mean, like
jump to point number 2.
Have more stuff to say about this. Really great conversation.
This was good. This was good. But we didn't even jump to any of the AI stuff. Half the hot takes are on AI. All right, so point number. I don't know how to like transition back into. Oh yeah, but what do you think of machine learning now?
Like and to your point of providing like a clinical guidance, right? Yeah. I don't even think clinicians like care how much you know, right? Like, but just being available and having those conversations and being like, here's what I know, and then here's who you should see next, right? Like when like an internist sends a patient to an orthopedic surgeon, they're not expecting them to be like, oh, you recognize their glucose was like 400, give them medication and then manage it and then bring them back to me. They're just like, as long as you recognize like that was bad and like send them to the appropriate place at that time. That's all we care about, right?
Yeah.
I mean, that this kind of ventures into the diagnostic side as well, right? When you guys form an impression, you obviously say, okay, there's a critical finding or results were discussed with X specialist, right?
Yeah.
Do you guys ever say recommend X consult?
I can say I was just on chest all the time, right? Like every time there's like a new like interstitial fibrosis or like a bronchial like obstruction, it's like consult pulmonology, right? Like who else are you going to do? And I think one of our attendings really goes to the point of like who's reading your report, right? And I think some of have talked about it, but like there's now the patient gets it pretty much automatically once you sign off. The referring physician does, but then everyone in every ancillary team can see it as well, right? And then depending on who's available, people with different varied like medical knowledge can see it, and they may need to then relay that information to someone else just verbally, right? And so like if it's not there, like you said, like maybe they don't know what to do with that information, because we talk in a lot of like imaging terms, right? Like UIP or like consistent with UIP. I didn't know what that meant a month ago, right? There's no reason that like someone outside of like a pulmonology like subspecialty clinic would know that. So like I think it's a very beneficial phrase.
Yeah.
So now here's the second part to that question.
Okay.
Do you guys ever attach the word recommend urgent X consult, right? Depending on the type of finding. I mean, so like if you detect a dissection, do you usually recommend urgent cardiothoracic consult? Or do you think people know?
I think when you say critical result and you call them, I think that speaks to the urgency. I don't necessarily think, and then when you say get a consult, I think it just carries on like critical finding, urgent, I'm giving you a call, and I tell you to do this. I think it speaks for itself. I don't add an urgent consult on top of the critical finding.
The reason why I say this is because sometimes we get imaging reports, right, from outside institutions. We don't have the images available. Read the report like, oh man, this person had a dissection, but here I think dissection looks bad, but it looks stable. But we think that the patient patient should still see a specialist. So that's why I'm kind of saying that, or you think, oh man, based on the description that they said, I think the dissection grew. So I still think they should see a specialist, but they should see the specialist now, as opposed to sometime later, right?
I think this is the place where the phone call helps, right? Because then you can kind of.
That is right.
I
That
think
is true.
that's
That
like
is
the
true.
point of the phone call.
I agree. Yeah. So I've never added recommend X consult, but I think exactly what you're describing. So I sort of relay the urgency through the phone conversation, use the words, hey, right now, consult, cardiothoracic, versus outpatient follow-up.
Yeah.
That's okay.
Yeah.
Yeah, that is true.
I think it'd be interesting to ask that same question a year from now.
Yeah.
Once we've all had call, right? Because I think, it's probably different from an outpatient scan that you're like, oh shit, there's like an emergent finding or urgent finding that like no one expected, versus like it's an emergency scan and you're like, oh shit, now I see something that like maybe it's like was completely out of someone's radar. And like, again, who you call, like, I think from a medical legal standpoint, right? Yes, you can say you called them, but then there's no way to say if you told them to do something else, right? Unless you put it in your report, right? And that's the documentation part.
So I think it's interesting because all we say is the results were discussed with X person, right? And they have to be a clinician, and you kind of put it in your impression.
Yeah.
I think people are under the impression that you've discussed at least the most pertinent things in your impression.
Yeah.
But yeah, you're absolutely right.
I mean, it sounds like, with quality improvement, like the talks we've gotten in the past week, like that's probably just enough of that like in between zone that like problems could happen, right?
Yeah, that's right. Yeah.
Sure. At the end of the day, our job is to alert them to what we see in the imaging,
Yes,
right? As long as we like the referral to is a cherry on top. That we do because we're trying to be complete.
Right.
I think the key thing though is like as long as you say like thoracic like aortic dissection that is like increasing, right? Like looks like unstable. Like they are absolutely able to take that and go wherever it needs to happen.
Absolutely.
Like if we if we say like we'll say refer like to like thoracic and they'll all pretty be like no shit. But and then they'll like hang up and do that.
It's interesting you use the word unstable. So I don't think that's a very good way of conveying the urgency of the finding, right? It's also interesting the words the lingo we pick and choose to, number one, convey a scale on the urgency of findings, but number two, to convey our hedges too, right? Like it's like consistent with, that must be it. We never say this is X. We say consistent with X. If you hedge a little bit less, we say, suspicious for X. Most likely favors this. Other differentials include X, Y, and Z, right? It's just interesting, man. But yeah, you're right. If I was trying to convey the urgency of the finding, I mean, the word unstable was not in my mind, but someone reminded me. I'm like, yes, that's what I would use. Unstable aortic dissection. I was going to use increasing, but I don't think it conveys the same level of critical result as the word unstable.
Some people would actually argue that increasing is better to use. Like stuff like unstable or worsening, like Scott Simpson gave me this lecture a few days ago. Actually,
shout out to Scott. Don't cut that out just so he doesn't.
You see the L's I'm taking.
But no, because like the thing is like it's like. Because sometimes there can be that we don't see the patient in front of us.
That is
right?
true. Right.
So like things like unstable, right? Like that normally implies like changes in their blood pressure and their vitals, right? Like, and we can't see that, right? It's like kind of like calling like attention. Like we can say suggestive of. Right. But like we can't actually be like, their pressure dropped because I saw we measured their veins and there was a difference.
Well, I was on call and just reading chest X-rays, and like the neuro fellow was on too. Super nice guy, and he was like had this exact conversation with me. Started kind of quizzing me, being like, in what situation would you like definitely not want to use like stable, unstable, analogous to like worsening or not worsening? And it was like say with MSK fractures, right, where like that stable, unstable is not blood pressure related, but it's just like the degree of that fracture. Right. And so for an orthopedic surgeon, like it's like OR, not OR in certain situations. Yes. And so like, the words we use have like an impact, right? And it's all like clinically like oriented and contextualized. Right. And so like it's just one of those language things. Like as we learn more, we're like, ah, shit, like we probably can't say that, and then we see a major change like the next morning, right?
Yeah, the context switching is honestly crazy. Like
Yeah,
we are like providing a service across the hospital, right? In the hospital, out of the hospital, and now to patients too directly, right? Like and trying to serve all these different people all at once. That's pretty hard.